Good evening, ladies and gentlemen. Welcome to our third annual colorectal dinner. It's a great pleasure to see you all this evening. A very warm welcome to our Vice Chairperson, Ms. Preeta Reddy, Apollo Hospitals Group, and Mrs. Chitra Rangabashim and Mahalashmi Rangabashim. It's always a pleasure to have you from Singapore and over here. So it's been a phenomenal few days in Chennai, as many of you are aware. March is Colorectal Cancer Awareness Month, and we've been talking and creating awareness about it in the last few days. We've had a good press con. We were talking about what symptoms people need to worry about or watch out. I know there's a dinner and you don't want to talk about colorectal, but it's very important that these symptoms are not ignored. So for the benefit of everyone, including myself, I'm going to repeat those symptoms. If you see blood in your stool for 6 weeks, I know, or change in bowel habit, or anemia or weight loss, get it checked. 6 weeks. And that's my message for the evening. So, so we had a very excellent symposium this weekend. We had over 300 delegates attending on the Saturday and the Sunday. And the phenomenal thing is this is in the third year, and we had people from the subcontinent, from Bangladesh, Nepal, Sri Lanka, the UAE, and also Singapore. So that's very heartening. So at this point, I would like to invite my co-chairs, Professor Stephen Wexner, Chairman of Colorectal Surgery at the Cleveland Clinic, Florida, and Professor Manish Chan, Professor of Colorectal Surgery at University College London Hospital. Onto the stage, please. It's our third year. How do you think it is all going?
Absolutely phenomenally well. This meeting has gone from strength to strength, largely due to you and your energy, and Manish and his energy. But it couldn't be done without the support of the Reddy family and the Apollo Hospitals Group, Hyatt here, the Hyatt Regency Chennai. But certainly the Apollo Group is committed to making this meeting successful. The good news is they've got you, and all they need to do is kind of wind you up and off you go. So the meeting is tremendous. It's gone from a regional meeting to a national meeting to an international meeting.
Winding me up is the easiest thing to do. You should ask Shubha. Yeah. It's like, press the button. Manish. Before you say that, I see you more often than I see my friends. And that's a bit worrying, actually. But, it's nice to have you in Chennai more often.
Well, I was going to say that this has now become my sort of home away from home. And every time that I come, it seems to be even warmer the welcome that myself and this time around we've had such a lovely faculty that have joined us again. In fact, some of them have been here multiple times as well. I think the meeting is getting bigger. The number of delegates this year was a record number of delegates. But it also, the hard work that goes on behind the scenes has become seamless now. And that's testimony to you and your team, and again, the support from Apollo Hospital. I'd just like to thank the delegates that have made the effort on a weekend to come. And they've no doubt been hopefully charmed by the faculty that we assembled this year, and also learned a lot. So thank you to the delegates, because they make the meeting, and of course yourself, the organization.
Great. Prof, one of the main objectives of starting this program, being subspecialization, and this symposium is to create awareness about this disease and to people to be openly talk about it. My friends are fine who are on Facebook because they don't have a choice, because every day they get bombarded with stuff. And so much so some of them started unfriending me, but I'm not going to stop. They don't have a choice. So do you think that's important to create that awareness and keep pushing the agenda? Because I think still young people are dying from this disease.
Absolutely, that's very, very true. Colon cancer, colorectal cancer is very unique in that it is largely preventable. And it is largely preventable because we know what the precursor lesion is, which is a polyp. And a polyp can be removed through a colonoscopy. The problem is that at least 50% of colorectal cancers occur without symptoms, so people don't necessarily go unless they have advanced symptoms. And worse yet, in young people, and the disease is occurring progressively more and more in younger and younger people, in younger people, the symptoms are usually ascribed to something else. Oh, it's hemorrhoids, oh, it's a fissure. And sadly, people at younger ages come in with more advanced disease than older people because the symptoms are ignored. So screening age is now recommended as 45 instead of 50. And I think even that probably needs to be, again, lowered. So creating the awareness is absolutely key. It is a preventable cancer. You know, you get a breast lump, it may already be a cancer. A spot on a chest x-ray may be a cancer. A polyp, you remove it, it won't become a cancer.
For me, what's heartening is when we had the first meeting, we said we'll start this multidisciplinary teams. So surgery is not a one-man show anymore. It's a team sport. And since then, we've been working on it, and I'm very pleased to say that our multidisciplinary team at the hospital is growing bigger because the other clinicians, the medical gastroenterologists, the pathologists, the radio, all are buying into this. And it's very important because for our patients, it's not one brain, it's working. It's a combination of all these specialists sitting on the table. What do you think, Manish?
Oh, I think you're absolutely right. And Dr. Albert, who's one of our faculty from Orlando, gave the talk on the role of the multidisciplinary team. And what I would say for those of you, please come and mingle with some of the faculty, and Dr. Albert in particular. He's sitting there at the front. Just put your hand up there, Matt.
That's because he's from Orlando, and you can go stay in his house when you go there.
So he shouldered a lot of the meeting today with a great collection of charismatic talks. But this is a multidisciplinary disease, is what Dr. Albert said. And if it's a multidisciplinary disease, it means it needs to be treated by a multidisciplinary team, which means lots of different doctors. You can't be an expert in all aspects of this particular disease. And I think one of the reasons that we found this whole project so exciting a few years ago when we talked about setting it up was that we could really see that we could make a difference by introducing the concept of a multidisciplinary team. And it's lovely to hear that you've now had that going for 3 years and are actually pioneering that in terms of the institutions around India.
Prof, we made a visit to our new facility earlier in the week, and your thoughts on that?
Well, Apollo also seems to go from strength to strength, and every time I'm here I learn about some new facet of Apollo, whether it's the scope and breadth of the hospital chain, the quality of the hospitals, the overseas locations, and then all of these other things like the pharmacy and the Be Positive magazine and the fitness centers. But this one topped the list with the Proton Center. This was just amazing. The rooms there, I don't want to insult the folks here at the Hyatt Regency Chennai, but on that level, shall we say, of a fine hotel. And downstairs, the patient treatment areas are as warm and inviting and friendly as they could be. It's still, a treatment center. But given that, it's designed as a very patient-centric place to be treated. It's not a pleasant thought to have to go be treated for cancer, but if you do, having it done in that environment is absolutely as good as it gets. And I know they're going to put doctors like you of that quality and other employees like you in there. I know we've got a huge pool, 75,000 or so employees, so they're going to definitely have the best and the brightest working in that environment, I have no doubt. It's really impressive. Manish,
you got a proton center coming up at UCL?
Well, not personally, yeah, but there is a proton center that is. We have the second installation in the UK at University College London. It's still not open. It'll be open sometime next year. And I was fortunate enough to be invited to the opening in January with the big event that was held here in Chennai. And it just is testimony really to the Apollo Hospital Group that they have this huge facility. It's no doubt going to have an effect to countless children as well as adults with the use of the proton beam. And another example again of absolutely first-class healthcare.
Thanks, guys. Thanks for the feedback. And now can I request the faculty to take their seats back in the audience? So, sorry about that. Stole my own thunder, I think. So, the Professor in Rangabhasham oration, it's our privilege to have this oration year on year. And when we thought about who would be the best person to name this oration about in the field of colorectal surgery or to commemorate what we're doing, our chairman, Dr. Pratap C. Reddy suggested that there's only one man, one doctor who could, fit that bill, and it was Professor N. Rangabhashyam. So, put your hands together for Professor Rangabhashyam, please. So, he's got numerous degrees and honors, born in 1963, and I've said immortal because I think that's very important. He immortalized how a surgeon should be, fearless, caring. And I invited one of my friends, Mr. A.V.M. Balu, and he sent me a message back to say, Prof is God to me. After all these years, that's how he's remembered. And I think that says a lot about the man whom we got this oration on. So, Professor NR was how he was called. Ward 10 was synonymous across the world and in the city particularly, because that's where he did his amazing work, and he taught his students, inspired them, and sort of this is how a surgeon should behave and be fearless, and that's what people learn from him. He was a pioneer in the field of surgical gastroenterology and coloproctology. Started the first surgical gastroenterology department in India at the Madras Medical College, and I think we're all grateful, this city particularly, for him to drive that specialty, and that we are all here because of him. He introduced the first MCH surgical gastroenterology program, and he was the honorary surgeon to the President of India and was awarded the B.C. Roy Award and Padma Bhushan, and many more. So I'm very honored that we have this oration on his name. So for the Professor N. Rangabhashyam oration for 2019, we have Professor Mariana Barrow, Chair Pathology and Laboratory Medicine, Cleveland Clinic, Florida, to deliver this oration. So she's got several academic appointments. She's Associate Professor of Clinical Pathology, University of Miami, Professor of Biomedical Science, Florida International University, Professor of Biomedical Science, Florida Atlantic University, Honorary Associate Professor at University College London. She is in several leadership positions, and her talk's going to reflect that. She's the Chair of Pathology and Laboratory Medicine since 2004, Center Director at the Research Institute from 2012 to 2016, Associate Chief of Staff since 2014, and more recently, Member of Board of Governors, Cleveland Clinic Foundation 2019 to 2023. And she's got lots of leadership positions across, and you can see that. I'm not going to go through that, but well-credentialed and well-decorated. And looking at academic activity, she's got 8 book chapters, 125 peer-reviewed publications, and to publish in pathology and related subjects is not easy, and more than 100 invited lectures. She's the editorial board of the Disease of Colon Rectum, Colorectal Disease, and Techniques in Coloproctology, and she's one of the finest pathologists related to colorectal disease in the world. Presenting to you, Professor Mariana Barrow, the 2019 Professor N. Rangabhashyam Oration Award.
Thank you so much. I'm so honored to be here talking about this topic that is very dear to my heart. And it's interesting because I was not always interested in women and leadership. I started being interested in this like around 10 years ago, when I started realizing that there was something not quite right when it came to women in leadership. And after that, I think it was almost like a passion developing, and I want to say that right now it's almost a mission for me, a mission to disseminate how important and how much women have to contribute to leadership in general. I wonder if my presentation is after this. Thank you. Let me start because, we are scientists. I need to talk about statistics. And when you look in general in the United States, women represent approximately 75% of the healthcare force, 75%. Right now, women physicians are around 34%. But when you look at women leaders in medicine, only 26% of chairs of academic institutions are women. And when you look at the C-suite, the CEOs, the presidents of hospitals, only 21%. And this is very interesting because in the United States, more than 50% of the medical students right now are women. So you can see how we are underrepresented in the leadership positions. Now, when you look in the past, there's a long history of women in medicine. One of the first descriptions of women physicians comes from Assyria, the city of Ur that is now part of Iraq. And this lady over here, Queen Shubhat, apparently was a very famous healer. She was always wearing her crown. Apparently it was a very heavy crown, but she liked to wear it. And there is descriptions of her cutting legs, supposedly for infections or helping delivering babies. And some time ago, there were some French scientists that were digging the areas in Ur, areas that they thought they were graves. And guess what? They found the crown of Queen Shubhat, and around it there was all of these objects that appeared to be surgical objects. So she was actually buried with her surgical instruments. In Egypt, there's also all kinds of references of women in medicine. This is the first female physician in Egypt, Merith Patah, and she mostly dedicated her life to women conditions. There were other physicians, but if in ancient Egypt, medicine for women was mostly related to female diseases. If you wanted to be a doctor for males, then you had to dress as a male. We also have a long history of female physicians in Greece. This lady over here, Agnodisis, she was an obstetrician, and you can see that sculpture that shows her helping a woman deliver a baby. Now, she could not treat males, but she really liked medicine in general, so she used to dress as a man until she got discovered. I mean, the reason that they didn't want females doctors treating men is that they were scared that the female was going to seduce the men. So when she was discovered, she was taken to trial, and apparently legend has it that all of her patients, male and females, gathered in the courthouse and asked for forgiveness. So after her, the laws in Greece changed, and then female physicians started to be much more common. You know that in Greek mythology, there is a lot of goddesses that are actually, females. These are Asclepius' daughters. He was the god of health. You can see that the names of the ladies are all related to medicine. We all know, of course, Panacea, that is the goddess of the universal remedy. After this, there's very, very little information about women in medicine, really. When you look back, the first real descriptions of women physicians are not till the 1800s. This woman, this is Elizabeth Blackwell. She's the first female physician in the US. She was actually born in England, and she moved to the United States. She didn't want to be a doctor, she wanted to be a historian. But apparently there was a friend of the family that had metastatic breast cancer and was in extreme pain due to the bone lesions. And this lady told Elizabeth, you know what, you need to become a doctor and help other women like me. So she reluctantly tried to become a doctor. She was rejected from all kinds of medical schools, and she finally graduated from a small medical school at the Geneva Medical College. There's these stories of the male students boycotting her, like they would close and lock the doors of the classroom so she couldn't come in. She finally graduated and she moved to France, and she used to work in a hospital for children. And apparently she was taking care of a baby that was born with gonorrhea, and the secretions came into her eye and she became blind. She wanted to be a surgeon, but obviously after that she couldn't. You will find the craziest stories over there. This is a woman that went by the name of John Barry, the beardless doctor. She was born a woman, Miranda Stewart, actually in Ireland, and her mother was very understanding of the fact that she wanted to become a physician, and she suggested to her that she needed to dress as a man. And actually she did. She went to medical school, she graduated, and she went into military medicine. It is said that she was a very good surgeon. She was sent to South Africa, and apparently she got very close to an English baron. Apparently they lived together. You can only imagine the rumors of the two men together. And she finally went back to England, and she died of dysentery. And they did an autopsy, and that's how they found out that she actually was a woman. And actually she had scars in the lower abdomen, suggesting that she had actually had a C-section and had babies. Now, when you look maybe 100 years ago, for example, the New York Obstetrical Society, they would not accept women in their society. And the reason for this, the reason that they gave, is because the meetings were held at a gentleman's club, and so the women would not be able to get in. The British Medical Journal, right, around 100 years ago, said that for women to become doctors, that was unnatural and preposterous. And they go further, saying that women that's seeking any time of higher education, not only medicine, will develop monstrous brains and weak digestion. This is a book that was written by Clark, and he was very convinced that it was unhealthy for women to become doctors or in general seek education. He said that what would happen is that the energy would go from the reproductive organs to the brain, and so females will become sterile if they study too much. So, thanks God we don't see these things anymore, but we still have some obstacles to become leaders in general, not only in medicine. So we have external obstacles, and we have overt discrimination. You know, people telling you something like, you know, you should consider a career that is easier than medicine. You know, not really, I don't quite understand what they're trying to tell me, and maybe I'm not smart enough. Or another one is, you need to decide if you're going to choose your family or your career. You know, I'm from South America. I'm a foreign graduate in the United States. When I moved to the United States, I cannot tell you how hard I worked. And at the end of my residency, I did very well. I got a few awards. And when I was finishing my residency, my program director, when he was giving me the diploma, the only thing that came to his mind to say was that my major contribution was that I gave birth to 2 of my kids. By the way, these are my babies. Daniela, she's 26. She's applying for a PhD in social welfare. She voted for Trump. No, that's a joke. In the middle is Franco. You know, I'm going to heaven with Franco. When he used to be 8, 9 years old, he didn't want to go to school ever. Every morning was a problem. So he decided, and I never realized, he would go in the car without shoes, and I didn't know. So when we get to school, he had no shoes. So we would have to wait till something opened for me to buy flip-flops. He managed to graduate high school. And then that's Mateo. I don't know, maybe in a couple of years I tell you what happened with Mateo. Now, we don't see that much of the overt discrimination, we do see still some hidden discrimination, because this is something called second-generation bias. And so these are practices and cultures that appear very natural, but actually have some hidden discrimination. Let me give you an example. I mean, the work structures are built by men, for men, typically. And a classic thing is we have meetings that are either very early in the morning or late in the evening. God forbid that you don't produce and your RVUs go down. So many times we have to take the kids in the morning, or at night we have to come back and do homework and cook. So we are left out of that. There's something called social capital, and that comes from networking. Women have less access to networking. You know, the boys typically go and after work, they go to happy hour, and a lot of business decisions are made at that point. We are not there, or when they go golfing, or when they go fishing. The second generation bias give rise to what is called double bind. So a double bind is a message, a very important message, that has two different meanings. And this is the situation in which you need to choose between two alternatives as if they were exclusive. So typically what we were talking about, you need to choose between having a family or your career. These double binds are based on stereotypes. We know stereotype is a very fixed, oversimplified image of a person or things in general. For example, I'm from South America. When I moved to the US, everybody assumed that I like rice and beans, and I had never seen beans in my life. In South America, it's too cold for that kind of food, so everybody was shocked that I didn't like rice and beans. So that kind of stereotype and generalization. Little girls play with dolls, little boys play with cars, and the classical, you know, women, we are emotional. When you look at those double binds based on gender stereotypes, you know, typically we women take care of people, men kind of take charge. So, you know, we women are nice, we're kind, we nurture, we are compassionate. More commonly, men will be described as assertive, decisive, authoritative, and risk-taker. So when a woman wants to play some of the roles that typically are played by men, it becomes a problem. So you need to choose what you want to be liked because you're nice and nurturing, etc. You want to be respected. But many times when we are assertive, it becomes a problem. So you sometimes have to choose between being liked and being respected. Both things is pretty difficult. So the problem with stereotypes is they become prescriptive. We are expected to behave in a certain way. So when men are assertive, but women, if we act the same way, we're called bossy. Men can take all the time they need to analyze the facts, but women, many times, we can't make a decision just because we need to take some time to analyze the facts better. Men are objective, women, the same situation, many times we're said to be cold. Men can get upset, can get passionate, but how often do we hear that when women are hormonal and the typical one is emotional, whatever that means. However, I want to say something. Besides those external obstacles, we have internal obstacles. We women, many times, have trouble identifying the leadership, the identity of a leader. For this is that we need to work on our emotional intelligence, understanding that we can do it. We need to develop that self-confidence. And then one of the most important leadership attributes is to have a sense of purpose. What is that I want, and why is that I want it? Sometimes we can be our own enemies, right? We have to do it all, and we have to do it perfectly well. And if we don't, we feel guilt, we feel shame. These feelings take you down. And I'm sure that many of the women here can identify with what I'm saying. You know that there's literature that has shown that women in general ask for less money when they're negotiating salary. And there is clear evidence when you look at women and men. If you look at the same type of education, a woman earns more than $7,000 less over a lifetime compared to a man. And why is this? You know, many times we're scared. We're scared we're gonna be called pushy or demanding. Let me tell you, there's still a gap between what a woman and a man makes with the same education. In the top is Western Europe, particularly Sweden, Norway, Finland, Denmark. These are the more progressive countries when it comes to equity. Still, a woman will make during their lifetime 76% of what a man would make. I want to tell you what happens when women break the stereotypes. This is a study that was conducted by the Harvard Business Review people. So they had a group of volunteers with a scenario in which it is in writing, and they give this written script that says that somebody, you don't give the gender at the beginning, a successful venture capitalist is going to negotiate a deal. So they divide the participants into groups. Group one, the person's name, the one that is going to do the deal, his name is Howard. In the second group, the name is Heidi. So guess what happens? The participants that were told the name of the guy negotiating the deal was Howard thought that person was pleasant, assertive. But for those that were told that the person's name was Heidi, there was a much higher probability that that person would be judged as selfish and unappealing. This is another study from the same author. Here is with college students, so these are educated people. And what they present is a scenario of a woman negotiating salary with her superior. Again, two groups. Group one, the woman is negotiating on behalf of somebody else. The second one, the woman is negotiated on behalf of herself. So group one describes that woman in a great way because we fit the stereotype of caring for somebody else. When we are asking for money for ourselves, there was more of a negative reaction. So what can we do? What can we do to address this? But I'm going to talk in medicine because that's where I understand a little better. There's structural changes that can be done. For example, changing the time of the department meetings, trying to accommodate the schedule of female physicians. Daycare facilities, it may not be possible to have it inside the institution, but maybe the institution can have some kind of arrangement with daycares that are around. Simple things, dedicated parking for pregnant women that maybe have to walk 2 blocks. Imagine in Miami during the summer that rains like it's the end of the world. I can tell you, our institution, Cleveland Clinic, has done a lot of these things. Now, let me tell you something. These structural changes alone are not enough. And I'm going to tell you, there's evidence, there's published evidence of this. Again, I already showed you how there's less women than men in science in general. And several authors tried to figure out why. And they came with 2 possible causes. One that is called the pipeline argument. And what they suggest is that, first of all, fewer women enter the science field, and we know already that's not true with medicine, but also that women leave the science field before getting to top positions. And the second reason is something called the deficit argument, in which women are less committed than men to their careers. And I'm telling you, this has been published. Let's look in academic medicine for women. Supposedly, when the editor chooses a reviewer, it has to be based on the expertise, right? It doesn't matter if it's a woman or a man. So there is this very, very interesting article that was published less than 2 years ago. Frontiers is an editorial. They have 142 journals in science, health, engineering, and social science. So they look at their data between 2007 and 2015. They have 9,000 editors for these journals, 43,000 reviewers, and 126,000 authors. So look at these numbers. Women authors, 37%, women reviewing, 28%, and women editing, 26%. So is it possible that is because already there's less women in academic medicine? It's possible. So what they did is they used a mathematics model that is called direct networks, and I wouldn't pretend that I understand it completely, but they wanted to answer the question, is it because there's less women doing this job? So they did a statistical analysis, permutation testing, and null hypothesis, and they saw that the fewer numbers of authors, reviewers, and editors remain below men even when they control for everything else. What is also interesting is that they try to extrapolate based on the current facts, and they figure that there'll be a parity between women and men as authors in 2027, reviewing 2034, and women editing 2042. I mean, hopefully I'll be lying on a beach at that, hopefully I won't be under the beach at that time, but I'm not gonna see this, obviously. Mariana, maybe you will see it, sweetie. You're young enough. So we said there's a second thing that we can do to improve this, and this is a much deeper thing. This is a transformation in the culture, trying to break what we call unconscious bias. We all have unconscious bias, girls, boys, women, men, on totally different things, but we're going to talk about gender. So the definition of unconscious bias in general is that inherent tendency that we all have to find a way to support our thoughts. And this is very much ingrained in our culture. We learn these things when we're growing up. And so the unconscious bias of different cultures obviously are going to be different. And to explain this, let me just 1 minute get some help from physics. Remember random versus systematic errors. Random errors, when you're measuring something, what you're going to see is fluctuations in measurements. There's just a tiny difference every time that you measure an event. These are unpredictable because they are external to the system, the instrument that you're using to measure. Now, the statisticians know about this. So that's why you want lots of events to be measured to correct for the random error. Instead, systematic error is an error that is going to be repeated over and over and over. The statisticians cannot control for this, and you may not even know that there is an error because you're constantly getting the same result. So let me give you an example. Let's say that I want to weigh myself, my scale, and I weighed 50 kilograms. So with random errors, one day is going to be 49.5, another day 49.7, another day 50.2. So there is accuracy because the numbers are close, but the precision is all over the place. Instead, with systematic errors, we keep on getting the same result. If we don't know there's a problem with the instrument, and as a lab person I understand this, you wouldn't even know that there is a problem. There's very good precision, but the accuracy is not good. So we can extrapolate this to the unconscious bias. If we don't know what we don't know, it's very difficult that we can correct it. Let me tell you, this I really suggest that you read this article. They wanted to see if they could find evidence of unconscious bias with women. So the first article, they reviewed 312 letters of recommendation for faculty that wanted to be promoted. So this is a retrospective study. So they compare the letters that were written for men and the ones that were written for females. And the ones written for females were shorter. They had more likely something we call doubt raisers. Let's say Mariana is a great pathologist, but ABC. The second one is a study done in Sweden, PhDs trying to look for positions for fellowships. And what they saw is that for women to be evaluated similarly to men, they would have to have at least 3 more articles in high-impact journals or 20 more articles in specified journals. The third one is my favorite because I think everybody can relate to this. This was done in Austria, and they were auditioning for players, pianists, violinists, etc., not singers. And somebody said, how come there's so many men and so few women? So they decided to do the auditioning in a blind way. So they would listen to the person play behind a screen, so they wouldn't know if the person was a man or a woman. And they saw that with the blind auditions, the likelihood of hiring a woman increased by 25%. So this is my point. If we don't know what we don't know, like in unconscious bias, how are we going to progress, to fix it? These are the levels of learning. This is in general for child development. So kids that are 5, 6 years old, they don't know what they don't know, and they're happy, right? There's no problems in life. Then you get to your teenager years, and you start to realize that there's a lot of things, well, probably after that, when you're a teenager, you think you know it all, but after that, you realize how many things you don't know. You can either get stuck there, or you can make the effort of trying to understand what's going around you, to the point that you are so competent that you don't even think about what is the right thing to do. When we're talking about unconscious bias, it's a similar process. I mean, you start at a status quo where you don't think there's any discrimination. What do you mean? You know, I have women chair, I have women in my panel, there's absolutely no problem. And then somebody comes and says, wait a minute, let's look at the statistics. That part of the resistance, the chaos, understanding, oh my God, maybe there is something there, and trying to get back up can be really difficult, and that's why people sometimes feel more comfortable with the old status quo. The ones that progress, they get to the new status quo in which you don't even have to think, oh, I'm gonna hire this person because it's a female or a man. You just look at the qualifications of the person. So ladies, we have come a long way, but we still have a lot to go. There's days, this is me here, there's days that I'm like really very frustrated, and I'm like, seriously? I mean, this is it. But we shouldn't quit. And the other thing I want to tell you is that it has been shown that the best mentor for a woman is another woman. So we need to we need to develop women in leadership so they can mentor the next generation. So I just wanted to finish thanking all the women that have paved the path for us. If we think it's difficult now, imagine how difficult it was before. And then, of course, thank you, gentlemen. I mean, I know that it sounded a little negative, but we wouldn't be here without your support. There's a lot of men that have helped us. And the last thing I want to say is I want to thank Steve, because he has always supported me, even in my crazy moments. And I tend to tell him, you know, I owe you my career, and he has always told me something that is in my brain. No, he says, I gave you the opportunity, I opened the door, and you ran for it. So thank you, Steve.
Thank you, Professor Mariana, but I think that was an outstanding lecture. Can you stay on stage, please? Prof, can you stay on stage? Can I invite my good friend and classmate from med school, Mahalakshmi Rangabhasham, to stage to honor Professor Barrow. Thank you, Maha. Can I invite Mahalakshmi Rangabhasham to say a few words, please? It's the third oration, and what do you think?
Thank you all for creating the time to come for an oration on a Sunday evening, an oration named after my father. I have to thank Dr. Reddy's family for keeping my father's name alive, and what better tribute than having a continuing medical education in his honor. Though he was, we all know that clinical work can swallow your research time and public awareness. But despite him having an illustrious surgical career, my father always found the time to run such programs. And Venki, thank you so much for keeping his name alive this way. All my holidays over the years has always been conference trips. So they won't be the typical holidays that most kids have. So a good half of my holiday would be listening to my father during these lectures. And I was thinking to myself, what would my father have said if he was here today listening to this lecture? The first thing that he would have commented is he used to, during my growing years as a med student, and the fact that I always aspired to be a surgeon more than a doctor itself, I remember having faced these moments of difficulties, and he would cite a lot of stories. So I remember him telling me the story of Dr. Elizabeth Garrett Anderson. She was the first UK doctor who apparently had support from her father in some sort of education. It was during 1836. And she role modeled on Elizabeth Blackwell. She was inspired by her. And when she told her mother that she wanted to be a doctor, her mother was horrified. So she had her first resistance at home itself. Apart from that, when she did want to pursue further in medicine, the British Medical Society would not permit her to be a doctor. So she had to either pretend to be a nurse in the hospital to learn medicine, but eventually she self-taught French to actually pursue a medical degree in France. Then eventually she came back, and it was probably in 1876 that they actually passed a rule in England that they could accept ladies in this field. We have our own Anand Gopal Joshi as well. But what I see as a unifying thread between past, present, and future for leadership in women is actually failure. Failure, why? Because we do face resistance, we do face obstacles. It's probably not overt and it's more subtle these days. The unifying thread with failure, what we need to learn and empower our ladies is that they probably need to learn to manage failure and find their inner voice. I don't say voice because I'm an ENT doctor, but I say voice purely because you need to find your voice during your moments of failure and despair and difficulty, and you've got to pull yourself up, have your faith, your perseverance, cultivate resilience to hold on to that inner voice to take you and march you forward through this. Thank you so much again, and I think apart from saying past, present, and future, one thing my father would have definitely said is how he admired Dr. Reddy and how he has empowered the leading ladies of Popolo for making an impact in the healthcare sector. Thank you very much.
Thank you, Mahalakshmi Rangabasham. Okay, so from the year 2019, Apollo Hospital Group and the Institute of Colorectal Surgery have instituted a Lifetime Achievement Award. This is for people who have given innumerable contributions towards achieving clinical excellence in the practice of colorectal surgery. So for this year, I think once I play these slides, people probably will know who the man is, but So he has got affiliation of professor of surgery for several of these universities across the US and the UK. He's published over 750 manuscripts, 260 textbook chapters. I mean, that's, you can't even imagine this. 130 editorial and invited commentaries. Editor and co-editor of 36 textbooks of freestanding volumes to date. I mean, to read one textbook is hard enough for us, A member of the 34 editorial boards and reviewer of an additional 37 journals. He's an active member of 42 learned societies and has held more than 70 appointed or elected offices in these societies. Just to stop there, if you send him a message, it could be any time, anywhere in the world. Usually, within 2 to 3 hours at max, you'll get a reply, or usually within the next second. And that's how the man doesn't sleep. So I think most of the colorectal guys know who this man is. He's an honorary member of the Surgical Service of 9 other countries and has held over 65 visiting professorships. He's delivered 2,100 scientific lectures all around the world. He's received 17 national, international, and regional awards for his research. So when I first met him, I was a very junior trainee. One of my bosses I was training in the UK. I had gone to the US. And there he showed, this is the professor who's running this show. It was in Fort Lauderdale, Florida. There were 1,000 people. This was 1997. To have 1,000 people or surgeons in a hall in 97, and they worshipped the way he was revered. And I thought, okay, I need to meet this surgeon at some point in my life. And I'm glad to say I've achieved that. This is very close to me. He trains 15 to 20 surgeons per year in laparoscopic colorectal surgery, surgical oncology, and the surgical management of inflammatory bowel disease. In that capacity, he has been a host educator to thousands of surgeons from around the world. And look at this. Best doctor everywhere. I mean, it's impressive. I don't want to go through it because I don't think we'll finish this evening. And I present to you the Lifetime Achievement Award for 2019 for innumerable contributions towards achieving clinical excellence in the practice of colorectal surgery. Professor Stephen Wexner, my mentor and good friend.
Well, very few words, really, just 2 comments. One, the best part of getting to do all of this stuff is getting to mentor other people. Because the idea of being an educator and being an academic surgeon is to try and make every single person who is your mentee have a career that ends up being better than yours, more successful than yours. And social media has enabled that more than ever before, to interact and to mentor people all around the world. And it's tremendously gratifying. I'm very proud of you and Manish, both of whom in the last several years we've had a phenomenal working relationship here and London, and both of you guys, your careers are soaring. You're going to leave me in the dust, and that's the best thing that can happen, that you guys take off on your own. The one thing, see, it's really easy. All I have to do is find guys like you and just, again, wind you up. The one thing you didn't put on the slide, which is the most important achievement of all, is being with Mariana, is having her figure out that she wanted to be with me. That wasn't on the slides, the most important thing. Thanks.
Ma'am, can I ask you to come and deliver the keynote address for this evening?
Ladies and gentlemen, what an inspirational evening. I just have one thought that if they had asked ladies to sit on those high stools they had a little while ago, especially us in saris, we may not have passed the test. But having said that, Professor Mariana, Professor Wexner, Venki, Dr. Manish, how can one say thank you to all of you? 3 years consistently to raise the awareness, to raise the bar on how an intervention can make a difference in people's lives. It's not easy to keep doing it year on and year out, but we've seen the progress it's made, and as Professor Wexner said, it's done very well for your careers. But what it's done is it's actually made a difference in people's lives, a difference in people's outcomes, and I think that's really why we're all here today and why it's so important. I, of course, have to make a confession that if my father, Dr. Reddy, had even one son among the 4 daughters he had, I'm not so sure I'd be here standing and talking to all of you. We come from an extremely traditional Andhra family, and I know that my father didn't let me go to medical school. Professor Rangabasham let Lakshmi go to medical school, but I know I got a seat in medical school after working very hard to get in. And my dad said, she has to get married, that's what girls have to do, especially from Andhra families. So anyway, he said that. I didn't go to medical school. I went to a dance school and I completed my PhD in classical Indian dance. And today I think I dance to everyone's tune. I know I do it to Venki and all the wonderful doctors we have at Apollo. Thank you all for being there, and it's such a pleasure working with everyone. And to me, that is the most important part of my career. Again, being a woman and being a girl, I look at it with a sense of gratitude because one, my father had no other option. And we as girls said, oh my God, dad is working so hard, so let's just go and help him out. So we keep telling him today, we say, we were such cheap labor. We just left everything and came here to lend a hand because, we couldn't bear the thought of him working 20 hours every day because, he was just setting up his practice in a very small clinic in Chennai when he moved back from the US. And incidentally, he left a very good practice in the US to move back to India for 2 reasons. Because his father said, if you're a big doctor in the US, it doesn't make any sense to me. But if you come back and serve your nation, then I will say my son did a great job. And then my mother told him, I don't want my daughters growing up in the US. I don't know why they were so frightened about girls growing up in the US. So anyway, they packed their baggage and they came back. And they came back with one fantastic car and a washing machine and a dryer, which they sold to start their first practice in Chennai. So that was the story of our lives, and that's how it really started. But anyway, my father set up this healthcare enterprise with a single-minded reason that, people from India shouldn't go abroad to, first they can't find the money, and the second is, why shouldn't India have quality healthcare? So he started this, and at that time, his really good friend, in a way a mentor, was Professor Rangabasham, and they worked together. And if we have the highest standards of, surgical excellence within the Apollo system, it's because Professor Rangabasham, insisted on high standards, clinical outcomes, and quality. And I'm glad Mrs. Rangabasham is here because she's seen us as youngsters. I've seen her and my mom sit together in so many clinical meetings and seeing the way the vision, the passion really grew. And it's done a lot for the country, and I think that's really what makes me proud. And sometimes I forget the fact that, I am a woman, I am a girl, because the men in my life have been extremely supportive. My dad literally pushed us, and believe it or not, he continues to do it. If we think we've achieved something and we go back to him with the report card, he says, but what is that? There's so much more to do. And today he's telling us, you have to keep people out of hospitals. What is all this about filling up so many hospital beds? You have to see that people are prevented from the onset of disease, people stay well, and you guys do whatever you want to do. Put all our revenues, all our capex behind keeping people out of hospitals. So that's how he's changed. Well, we are so proud of the Proton Center we built. After it's inaugurated and it's doing okay, he's now bothering about something else, about literally keeping people well. So I think that's what keeps us going day in and day out. Being a woman, you have to acknowledge the fact that your spouse allows you to do what you do, and also, in a way, keeps you out of trouble. Because I think if the women are busy and they have to get up and go and worry about somebody else and something else, then there's harmony at home. So I think a secret of a successful marriage, and I've been married 43 years, is the fact that, my father and my husband have just said, just go out there and work, because that's what you need to do. And then I have 2 sons. They can't imagine a mother sitting at home, and so, they've allowed me to work and they've appreciated me working, and I have to be grateful for that. And now I have a grandson. I'm not so sure if he, really wants me to work, but I realized something today, that Captain Marvel is actually a woman, and he told me that. I didn't even know that, but he said, Amama, Captain Marvel is a girl. So I think, it's not so bad actually being a woman, and we just have to be able to forget the gender bias, maybe sometimes be conscious of it, but kind of, do it well. And Professor Mariana, you showed us how to do it well. So thank you for that spectacular keynote. It's just inspired us to do so much more, and it's been wonderful. What is an institution all about, especially in the healthcare space? And I think I'd just like to take a little while to tell you, the way we focus and the way we think it should be done is that an institution has to focus on being AAA. For those of you in finance and sitting in this audience, you might look at a AAA rating where you'd like to put your money in. But we healthcare professionals look at a AAA where we put our careers and our life in, because I think that's what a good healthcare institution has to be. So what's the AAA? I think the first A is about being accountable. The second A, especially in a country like ours, where people literally pay from out of their pocket, is affordable. And the third A is accessible, because we have, fantastic cities, but India, which is Bharat, lives in the villages, in the remote locations. So accessibility is a huge issue, and this is what institution building in India is literally all about. So when we say accountable, it's all about outcomes. It's outcomes, outcomes, outcomes. When somebody trusts you and they come into your institution, you are committed to delivering the highest possible outcomes available anywhere in the world. If you can do better than that, that's good. You should be able to raise the bar. But you must deliver the barest minimum of high quality outcomes. And I think that's why we have, sessions, we have training programs, we have people learning laparoscopic work, robotics, and lasers, and proton, and every imaginable gadget, we start looking at it. But it's only because we're committed to the fact that outcomes are so important to us. We have to look at a multidisciplinary approach to the way we treat a patient, because it's not really a relationship about a specialist and a patient or a customer or their families anymore. It's this whole agglomeration of knowledge which is available in the virtual world. And if there is some speck of something which can make things better for them, we have to be able to deal with it. So I think a multidisciplinary team is the way to treat a person in the future. And I'm glad that everyone started thinking along those lines. Of course, we are dealing with Dr. Google all the time. But having said that, at least, more heads are better than just one head and one mind. So I think it's important. We have to invest in the best because I think people are entitled to it. They trust us for it. And we need to find the way, the capital, the focus on investing on whatever is the best. We did it at the Proton Center, and Professor Wexner, thank you for visiting and telling us that it's a great place. If it had great outcomes, I would be delighted. We've already, from the time we've started, we've done about 20 patients. A lot of them have been kids. And if it's going to make a difference in their lives, I think it's truly worthwhile what has happened there. We can't, not think about the importance of artificial intelligence or machine learning in the future, because it's going to come up with a lot of options on treatment protocols. So an investment by an institution into seeing what is the future with artificial intelligence again becomes primarily important for us, and I think we as an institution will do it. On the affordability factor, India is a country of 1.3 billion people. Out of that, half of them can find some way or the other to access high-quality healthcare. There may be a third-party payment, they may pay out cash out of their pockets, but they will find a way to get into specialist centers. But what happens to more than the other half? And I think that's why Ayushman Bharat, which was very daring, which was something all of us worked with and are part of, that has been now initiated in the country. And the way I look at it, there's a long way to go. There's a lot to be done. But I think it was a daring move, and it's something which will give people access to the highest quality healthcare and really make high quality healthcare affordable to people. So I think we have moved in the right direction. While the journey is long, I think it will get much smoother than what it was before. The third issue, of course, is accessibility. We have to pass the test of financial access, but there's geographical access also. And India does live in its villages, and we know we don't have enough clinicians to really meet that need. So there are many different approaches. We've used technology now with telemedicine to take healthcare to the remotest locations available, to the highest point in the Himalayas, to the ends of to the tip of India, let me say, because it's somewhere in Kanyakumari. So we kind of pan the whole of the Indian map. But having said that, I think there's a lot more to do. And can we really give people that point of care which is, beyond the doors of the hospital? And to me, that again is a future challenge, but it's a challenge which will be met. And so while we're, managing healthcare institutions in different ways, the gender bias, I guess, is not so much with us. But I think we have to be conscious of it, because there is a dual responsibility to do what we have to do, and never forget the fact that there's an added responsibility about, in India it's about looking after the elders, which becomes then at this age a very primary responsibility, looking after our families, which I think all women do extremely well. And having said that, excelling at work is something which we're all passionate about, and we kind of owe it to society. So if you tell me that has it been easy, I don't think so. But has it been exciting as a journey? I think so, because we've had tremendous amount of support from not only people at work who work alongside us, but our families and society at large. India surprisingly has recognized, women in power much more than many other nations. I don't know if it's because that the goddesses are only in India, not in any other religion, only in Hinduism. You know, you have the goddess of wisdom, you have the goddess of power, and you have the goddess of wealth. But then you have male gods as well. So I don't know how it works, but I think from somewhere up there, there's an energy which is blessing all of us and telling us that we have a great responsibility, maybe a bigger responsibility than the men because maybe we feel it more. But having said that, I can promise you that not only the women in India, but the women in this room who've come from all parts of the world, and women globally will just rise to meet the challenge of keeping people healthy, of nurturing the environment because it really needs it, and making the world a better place to live in. Thank you all for the invitation, and to all our guests for coming from different parts of the world to be there with us. And Venki, of course, thank you for the invitation, may your tribe grow definitely. Thank you.
Thank you, madam. I think we've had a great evening, and as we close the formalities, I invite you all to join us for a drink and dinner later. Thank you.